And I'm very happy to introduce Andrea Ioboni, who's a geriatric psychiatrist at UHN in Toronto. Very well-known researcher, clinician, connected and experienced in long-term care. And Andrea is going to speak with us today about ethical guidance and tools for people working in long-term care. With that, I'll turn things over to Andrea to speak to us about ethical guidance and tools for people working in long-term care.
Well, thank you everyone for being here today. It's strange times, and it's great that everyone still is carving out time in their week to learn and to meet and support each other. And so I'm really pleased to be presenting to the ECHO today. I've heard so much about the work that you guys do, and very keen to share with you some of the work that we've been doing in this area. In terms of commercial interests, I do receive grants, but they're all from not-for-profit foundations and other national agencies. And I have consulting fees as a scientific advisor for an app, but that does not affect the content that I'm presenting with you today. Is not a conflict. So there's no specific conflicts to disclose today. I'm going to be speaking to you about this ethical tool that we developed as part of something we're calling the Dementia Isolation Toolkit project. And so this is the first of what we hope to be several tools. The second tool is well underway in terms of preparation, and I hope that we can send that out to you guys in a week or so. But for the moment, we have this one, and I think this one is actually one of the most important ones. And the way it came about is that so I'm the director of a specialized dementia unit here at Toronto Rehab, and so we bring people from long-term care with responsive behaviors. And at the beginning of this whole pandemic, we started doing some planning, and we realized that we were really not well positioned in terms of how we would manage if we had an outbreak on our unit. We have almost all of our patients on our unit are ambulatory, have responsive behaviors, and are, and how would we face needing to, implement infection control processes in our unit? How would that work? And so that was in part some of the struggles we were having. And the first thing that came up was a lot of ethical questions about how we make decisions about this and what kinds of decisions we reach. And that sort of drove the development of this first tool. I have this here just to provide you guys, to bring us up to date. We know that long-term care has been really badly impacted by this pandemic, and it counts for 50% of deaths across Western countries. But in Canada, it's up to 80% of all deaths in our country are in long-term care. And this is the numbers from Ontario. And so it looks like we have about 27% of our long-term care homes in Ontario right now on outbreak. But what's really clear when you look at the data is that there is a big variety in terms of the extent of the outbreaks. There's some, homes that are really badly impacted with large outbreaks affecting large number of staffs, large number of residents, and a large number of deaths. And then there are many long-term care homes that are actually have been quite successful at containing their outbreaks, such that they're very small and focused. And so, we may not be 100% effective at keeping COVID out of our long-term care homes, but the idea behind this project is once it is in the long-term care home, how do we effectively control the spread of the infection? So this is just to summarize, all of the sort of infection prevention strategies that have been implemented. So these are all about stopping the infections from even getting into long-term care. And then if there is, an outbreak in a long-term care home, all of the different things we're doing to control infection. And one of the sorts of key elements of control is the idea of isolating suspect and confirmed COVID-19 cases. And there are obviously a lot of different ways of keeping those people who are infected, who are ill, away from those people who are not. And one of those is cohorting. So that's where you create your COVID-specific units. And then the other way is obviously keeping residents within their rooms, and preventing the transmission between residents. I have to say, this is really important to point out, is that we don't actually have a lot of evidence so far about how much of the spread of the infection within a long-term care home is from resident to resident. We certainly know that the initial infection often seems to come from an asymptomatic or minimally symptomatic staff member who brings it in from outside. But then once it's in the facility, is it being transmitted primarily by staff, by residents? That kind of information we don't have yet. But it's presumed that a certain degree of the transmission within a home is from resident to resident. And so how do we address that? So this is just a summary of some of the evidence we have so far about what's contributed to spread in long-term care homes, and it's based on a very limited research that's been done to date. But it certainly seems that staff working who are sick or working in more than one facility, and working while symptomatic, but also working asymptomatic. I mean, I think for the most, we now know that there's a large amount of asymptomatic spread. Inadequate PPE was certainly an enormous issue at first, and hopefully has been mostly addressed. The limited available testing was a big problem, but that's also hopefully been addressed. Delayed recognition of cases. We're getting much better at knowing when people have COVID-19. We're starting to really realize that it presents in a lot of different ways, and that obviously a lot of it is asymptomatic. But one thing that we know from research more generally in terms of outbreaks, and a lot of this research was done before COVID, is that there is a real challenge in terms of recognizing an outbreak when it's happened, and some delay in implementing control measures, right? So that we recognize the outbreak is there, and then we start to put into place the control measures. And so that delay can be really crucial. And then finally, insufficient use of isolation and cohorting has been a problem more widely in long-term care. And there's a lot of good reasons for this, in part because it seems to be quite a negative restriction to place on residents in terms of their quality of life in their homes, in their long-term care homes where they're living, to, compel them to stay in their rooms. And it's not as easy as it seems, particularly in residents who are ambulatory and who cannot understand or follow requests to stay in their room. And so the idea behind this project was really focusing in on this idea of how do we achieve these infection control measures in a way that is safe and compassionate. A lot of what the initial the conversations that I was hearing about this were very black and white, this idea of, well, either they stay in their room or we're going to have to make them stay in their room, talking about leaping right away to quite restrictive measures. And so this was really about us coming to our decisions and our planning in this area in a way that is thoughtful and in a way that is reasonable, and that takes into account the sort of ethics of care and our duty of care to people with dementia. So one of the things I'm hoping you guys will talk a little bit about are what are some of the barriers you're facing right now to being able to put into place isolation or other infection control measures. And so there are a lot of different kinds of barriers. People are finding that the directives seem to come in conflict with different kinds of policies and practices, and are struggling in that area. The actual physical environment of a lot of long-term care homes is not conducive to this. The 4-bedded rooms, just not enough space. No ability to really, close off parts of a unit. Staffing resources, obviously. So something we're really aware of now is that once a long-term care goes on outbreak, often there is a large number of staff who are ill as well, and so there's a sudden loss of staffing resources in a facility, and so that's an important barrier. If you had enough staff to provide one-on-one support for someone who needed to be isolated, then it wouldn't be a problem. Safe equipment, is what you might need in terms of physically securing the environment, enough door alarms or other things like that, having the training and procedures in place. And then the last two are really about barriers that are within ourselves. One of them is the moral distress of, feeling like this is something that you should be doing, but not really feeling like you have enough tools to be able to do it, and the kinds of distress that creates in us. And then just basic fear of the implications of trying to isolate someone, and also the implications of not trying to isolate someone, that can actually be quite paralyzing. And so our thought was that what would be really valuable is having some more clear guidance. And so I'm just going to skip past this because I want to get to the actual tool itself. And so the toolkit that we're developing, the idea is to have some frameworks to help us think about decision making in this context. And then the last part is to developing some two-way video monitoring and communication systems using simple hardware. And this is something that we've found very useful on our unit, and something we want to be able to share more widely across long-term care to help people build it themselves. So this is the tool, and I think hopefully a link was sent out to this if you wanted to be able to download it and follow along. And it is available for anybody who needs it. And it goes through a few different things around the ethics. And the reason why the ethical guidance is helpful is that it helps address the moral distress, like the sort of paralysis around decisions that you can get into when you just don't know what the right thing to do is. And so this helps you decide what you think, based on the information that you have and the resources you have, what the right thing to do in a particular situation is, and a process for reaching that decision. And then that will hopefully overcome some of that paralysis. And so it goes through a bit about what a pandemic changes in terms of how we think about individual rights and freedoms, for example, and the kinds of decisions that we make and the kinds of difficult decisions that we face. And I think that in some ways, this tool doesn't just apply to the issue of isolation. It applies to all of the difficult decisions that we're making every day in long-term care, decisions about, you know, visitors who want to come in, or decisions about, you know, other kinds of like whether to admit people to your facility or not, whether to bring someone back who's ready to be discharged from hospital, or, you know, all of these sorts of questions. And so the idea is that we take into account these principles when we make a decision. And the guide goes through in a little bit of detail what each of these principles mean. The basic gist of it is that proportionality means that the action has to be proportional to the risk. You don't want to overreact or underreact. It has to sort of match the degree of risk. You want to minimize harm in any decisions that you take, because, you know, the burden is falling on the shoulders of these residents in terms of protecting others. And so we need to make sure we minimize harm. And that also fits under reciprocity, that they're giving up their freedom, and in return, we have to address, you know, support their care needs and make sure that that isn't unduly burdensome to them. Then the issues around fairness, like we can't apply these principles unfairly, like to some residents, but not some others. And then the idea of transparency, that every decision that we make has to be very clear to everyone who's involved in it. And so then the tool itself, and I'm not going to spend too long on this, but it goes through a few of the infection control principles about why we isolate people who are contagious. And, you know, it shows really the impact of having, you know, one person who spreads the virus more widely can change from a small outbreak to a very large outbreak over a short period of time. And so how these principles really need to be tried to applied consistently to any resident who has a risk of spreading the infection. And so then the question is, what do you do if a resident isn't able to stay isolated? And so it takes you through this idea of what are the different options under such a circumstance, and how can we approach this problem? How can we help someone stay in isolation? And it presents what we call an infection control and isolation care plan. And the idea is that any plan that we come up with has to address these 4 issues. We have to try to address personhood, because the reason why someone comes out of their room is different for every individual. We can't treat each person the same. We have to find a way to engage them in their room, or we can't expect them to stay in their room. There's no way I would stay in my room staring at a blank wall for 24 hours a day. We need to find a way to support their needs while they're in their room, and we have to find ways of cueing and reminding them that they need to stay in their room. And that if we address all of these and they're still not coming out of the room, then at that point, then it might be justified to consider a more restrictive approach. And it goes through also thinking about what the risks are of some of these different approaches and what we need to consider. So this is how the tool is structured. And so the idea is that at first you think about whether there is the necessity for isolation and what dictates that, and how big the risk is, and whether it justifies the following steps. And then you go through a process of using least restrictive to more restrictive. And the reason why the arrows are kind of going in all directions in this graph is that it's not always exclusively least restrictive or more restrictive. If you have to use some more restrictive measures, you're not stopping to use the least restrictive ones. You're always using a combination of least restrictive and, if necessary, some more restrictive. But it's not either or. It's both. And you should always be using the least restrictive measures at all times as well, because to minimize the need for more restrictive measures, if that makes sense. So this was the idea behind this, is to really shift our thinking away from the black and white, that it's one or the other. It's really both, if needed. And so the tool itself has this worksheet, which we're eager to get feedback on. It obviously doesn't have a lot of space. It's our first sort of go at it. But the idea is it takes us through some questions about personhood. So who is this person? What kinds of reasons bring them out of their room and what helps them to return to their room when they leave it. And so really thinking about this a specific person. And I do have some cases that I'm happy to talk to about later, but I'm also interested if people have cases that they are struggling with, and we can certainly try to use these to go through it. Then the engagement aspect. So how are we going to engage them while they're in their room? What can they do in their room? What do they enjoy? What do they like talking about? Who do they enjoy spending time with? And then this idea of reminders. So what can we do to help them? Oh, sorry. First, supporting needs. What do they need help with? What can we do that will bring them joy and pleasure and reward them for staying in their room? And then what kinds of reminders are valuable for them to help stay in their room? The idea behind the thinking about the supporting needs and also reminders is that the hope is that we find ways to engage people while they're in their room and not wait until they come out, because you can get into a vicious cycle of reinforcing them coming out of their room as the time when they get engaged, right? So if they are lonely and they know that if they come out the room that then the nurse is going to be there right away, then we're reinforcing them coming out of their room. So really the aim is to engage them in their room so that we reinforce them in their room. We thank them for staying in their room. We reward them for staying in their room. And so we are reinforcing that behavior rather than leaving the room. And so the idea is then you come up with these approaches and strategies that you're going to try, and then you try them. And then the next step is then around decision making. So you've come up with an isolation care plan, and then the decision is this plan been effective or not, and what are the next steps? And so the idea is that and then again, this decision making can apply to any sorts of COVID related decision making, is that any decision that we make is reasonable, that sort of takes into account all of the information that you have, and that someone from outside who looks at what you're dealing with would look at it and say, yeah, that was a reasonable decision. That it's responsive, so that the decision making needs to be kind of fast, but it also needs to respond to things that are changing, so that you have to have a plan to go back and reassess your decision. You have to reevaluate as the situation changes. So someone who was COVID positive 2 weeks ago may not be COVID positive anymore, and obviously the decision that you need to make is different, and you have to reevaluate. And then the idea is the decision has to be open, has to consult everyone who's involved in some way. You have to show some accountability for the decision, and that you have to have a decision that engenders trust, because otherwise no one is going to, if they don't trust the decision is good, they're not going to implement it, and it's not going to be an effective decision. And so this is the decision tool that we include. So you start off by asking, what is the danger you are trying to prevent, and how likely is it? And then, so for example, in a recent case we had a woman who was COVID positive who was coming out of her room a lot. And when we sat down and thought about the danger, she was only coming out of her room to just outside the threshold of her room. And then she would stop there and she would vocalize loudly until staff came to help her. And she was in a wing that was all COVID positive. And so actually we thought the danger was very low. There was a behavior, she was coming out of her room, but she wasn't coming into contact with anyone who was COVID negative when she was doing this. And so that's like the first step is trying to decide what the danger is. And then you think about the strategies you're considering, the strategies you've tried, the risks, the benefits, and whether they've been effective. And then think about who you've consulted, or who you should consult at least, and their input into this decision. And then you decide on what the chosen plan of action is. And then you think about how you're going to communicate this plan, because it's no good making a decision if you don't tell anyone about it. And then you think about how you're going to minimize the risks that you've identified with this plan, because every plan will come with some risk. And then you're going to track the plan, how effective and safe it was, and then have a plan to come back and reevaluate it. And coming up, and at what point is it necessary to think about whether this is working or not? And that might be like one day, or it might be a week. It depends on the decision and the context. So I need to acknowledge the people who have been working on this with me, who are and our various partners.